Thank you. A complete different disease that doesn't exist, I think, below 20 years of age. I have seen only one publication on a girl with a localized amyloidosis. So sorry for pediatrician. So I'm very happy to have this debate with Stefan Schönland. He leads the hematology unit who takes care of amyloidosis, the referral center for amyloidosis in Germany, in Heidelberg. And we have been discussing for years in all amyloidosis meetings on high-dose treatment in this disease. So the question is there still a role for high-dose treatment in amyloidosis? And my response is yes, certainly, but very tiny and not in first line. So in amyloidosis, there is usually a small dangerous B-cell clone with a low proliferative index. Patients usually have MGUS or smoldering myeloma, and the evolution to a symptomatic myeloma is very rare, as you can see in this very huge series from the Mayo Clinic. And one important thing to consider when you think to the treatment in this disease is that the plasma cells are stressed by the abnormal amyloidogenic light chain. And that gives a high sensibility to certain drugs, proteasome inhibitors and dexamethasone, and a lower relapse rate compared to myeloma. But also there is many organs involved in this disease, and organs function is frequently impaired, particularly heart and kidney. And the prognostic is really depending on heart involvement, as shown in this three staging system from the Mayo Clinic. It's the classic one from 2004 using NT-proBNP and troponin. The European one with stage 3A and 3B, depending on the value of NT-proBNP. And the next one from the Mayo Clinic with DFLC is the difference between the value of the monoclonal and the polyclonal light chain. And it's not good to have high DFLC. It's not good to have high bone marrow infiltrations. But the worst patients are really the 3B with a very poor survival. The other factor which is very important for prognosis is hematologic response. And you can see that the survival is much better for patients in CR or in VGPR. VGPR is DFLC below 40 milligrams. So the treatment of amyloidosis is to kill plasma cells with specific treatment. And if you have an hematologic response, involved organs are getting better, most of the time slowly, with different speed in different organs. It could be relatively fast in the liver. As you can see in this patient, he was a man who was relapsing 3 years after an autologous stem cell transplantations, and you see that his gamma GT are going very high, and we obtain a rapid complete remission with normalization of free light chain, and he received 5 cycles of bortezomib and dexamethasone at this time, and is still in complete remission now 10 years after. And as you see, his liver is completely normal. And you have to always to think that chemotherapy is not directly active on amyloidosis deposits. So the work of chemotherapy is to lower the free light chain level. So in the early 90s, the treatment was not really efficient with MP, with only 1/3 of patients responding and a survival around 1.5 years. And the first high-dose treatment was reported in 93, and the story starts badly because the patient died in the intensive care unit. But rapidly, Recomenzo from Boston published 5 and then 25 patients with really good results and a much higher response rates, 65% instead of 30%, 30% with really impressive clinical response and neurologic in this case. But as very rapidly we understood that TRM was a real problem in this disease, treatment-related mortality. And in this retrospective study published by Philippe Moreau in 2007, 21 patients, multicentric retrospective study in France, 43% of the patients died before 1 month after autologous stem cell transplantation from multi-organ failure, from bleeding, from cardiac arrhythmia. So it's not only after the high-dose treatment, but before, that you can have problem in this disease, and mobilization could be complicated. And in this very recent published study on 101 patients, 41 patients have problem during the mobilization and 4 died. So why to choose autologous stem cell transplantation instead of conventional treatment if you can have a better response rate, a better PFS, or a better survival? But in the early 2000s, we introduced, along with the Italian team, the Association of Melphalan and Dexamethasone, MDEX, and they published a phase 2 study in 2004, and we did a randomized trial. It's the only at this date, randomized trial comparing high-dose treatment versus conventional treatment. And both in the Italian study and our study, the response rate was exactly the same with MDEX than with autologous stem cell transplantation. So, same response rates, lower TRM, the survival was much better in the MDEX arm than in the high-dose arm. And is it still true 10 years after? So we did a long time follow-up, more than 11 years, and we found no advantage for autologous stem cell transplantations. Even in the landmark analysis, taking into account only patients who received their treatment and who were alive 6 months after the treatment. So it's 0% TRM, it's 100% feasibility, no advantage in survival for high dose, and no advantage for survival in the landmark analysis. And it has been published by an American team, same no advantage for high-dose treatment in this retrospective study, even if the patient in the conventional arm were more severe. So better response rate, no. Better PFS, no. Better survival, no. But higher TRM and higher morbidity, as shown in this study, with some patients who have renal failure in the months following the high-dose treatment. And these patients have a very poor outcome. And my friend Frank Bridou wrote this editorial. And is there still a place for autologous stem cell transplantation for patients with renal disease? No. And after our trial, many other treatments came, and the really important thing was the introduction of proteasome inhibitors with very high response rate, 94%, it's 65% with high-dose treatment. And it could be traduced in a very good survival rate. In this collaborative European study, the good patient in this study, it's 100 estimated survival rate with bortezomib, cyclophosphamide, dexamethasone at 5 years. So, better response rate, no, lower than with new regimen. So why so many papers argue for autologous stem cell transplantation superiority? And for example, in 2004, in Blood, in an editorial, Jayesh Mehta from Chicago what the data from the Mayo Clinic and Boston University are impressive enough to make a prospective randomized study of high versus conventional dose therapy in amyloidosis scientifically unattractive and practically impossible. It was 3 years before we published our study in the New England Journal of Medicine. So what was the bias? Usually, the data are reported not in an intent to treat. Patients who did not receive the high-dose treatment, they are not in the paper. The reports were done often in very specialized centers. And the main problem is selection of patients. When we look in our trial, high-dose versus conventional treatment, when we take good patients and bad patients, whatever the treatment, there is a huge difference in survival. And when we look at many papers, like this one published in BMT, they take the patient who receive in their center high dose, the patient who receive a conventional treatment. Sure, there is a difference, but when you look, patients are younger in the high-dose treatment with less organ involved, with less cardiac disease, with less bone marrow plasma cells. In this paper published last year, it's exactly the same, and you can see the BNP, it's very important cardiac marker. It's 192 in the autologous arm and 500 in the MDEX arm. In France, we have an algorithm to treat patients depending on severity of cardiac disease and response rate, with melphalan dexamethasone for low-risk patients, adding bortezomib for non-responder, and VCD, bortezomib, cyclophosphamide, dexamethasone for stage 3 patients. And here is a survival curve of a non-selected series of patients treated in 27 centers, multi-center studies. Median age was 68, 40% of patients were more than 70 years. And when we apply to this series the criteria from the Mayo Clinic to be eligible for high-dose treatment, here is the survival. It's 20% of our patients, exactly the same percentage that they have at the Mayo Clinic, and that it's 96% of survival at 2 years. And the Mayo Clinic tried to do an autologous versus MDEX study, but they only could randomize 4 patients in this study, the American patients that don't like to be randomized. So they did the study with patients who choose their allotted treatment, and the high-dose treatment was better, but one more time, they were younger if they choose the autologous stem cell transplants, and with less cardiac disease and with really less lower DFLC. So both arms are not equal. Another problem that I think in making this presentation is why melphalan 140 is so bad in amyloidosis. When we do high-dose treatment, usually we give to the patient 200 milligrams per square meter of melphalan. And for aged patient or frail patient, we give 140. And in amyloidosis, 140, it's really not good as writing in this paper. And it's not the case in myeloma. Myeloma with a much bigger tumoral mass, it's exactly the same in this paper published this year, 2000 paper, same survival, same PFS, and not in amyloidosis. Why? Because in amyloidosis, when you look in this paper, in the reduced intensive group, they are older, with more organ involvement, more cardiac disease, more patients in stage 3, more NT-proBNP much higher, and higher DFLC. So it's only, I think, a question of selection. And the tendency now, and we just have a discussion before with Stefan, is to give first conventional treatment and then high-dose treatment. But why to give a risky treatment for patients? You can have this kind of PFS, of very long-lasting response in this patient 10 years after 7 cycles of MDEX, and she relapsed, but she obtained a CR very rapidly with VCD, and this one 8 years, 9 years with only 5 cycles of chemotherapy. And now we have many new drugs. The last one is daratumumab, and we have done a small study, prospective, 40 patients, with really good response, very rapid response in patients in relapse of refractory. So, in conclusion, no evidence-based medicine to support autologous stem cell transplantation in first line in AL amyloidosis. Higher TRM, it's only 5 to 10% in expert center, and probably more for center with less expertise. No longer remission duration, no better response rate, lower than with bortezomib containing regimen, and we are going to begin a study comparing VCD and VCD plus daratumumab, and I think it will be even better. So what is the tiny place for autologous stem cell transplantation in amyloidosis? For non-responding patients with an IgM, it's very difficult to obtain good response in these patients. Patients with a symptomatic multiple myeloma and no severe organ involvement, and young patients without severe organ involvement who are refractory to almost 2 lines of treatment, but it's not sure now because we have daratumumab and soon venetoclax. So thank you for your attention. Thanks for all my colleagues of the French network, and thanks really to Stefan for coming.
Yeah, it's hard to come from Heidelberg to Paris and talk about pro-transplant, but I think we are not so far away from each other, actually, if I see your last slide. Okay, so I will talk about there is a role for high-dose treatment. And you have seen this already for the myeloma patients and now also for the light chain amyloidosis patients. A lot of treatment available nowadays. Good, effective treatments available, and now it's the problem how to choose the right treatment for the specific patient. And here, I think, actually, it's not that hard. And selection is the most important thing we have to do with the patient. And at the end, you can distribute those patients, those AL patients, in 3 types. You have the patients with a low risk, and they are transplant eligible. Actually, they can be treated like myeloma patients. And why shouldn't we not treat like myeloma patients? They have a plasma cell dyscrasia. They are not sick, actually not sicker than myeloma patients, and they can stand the treatment. And then they will have the profit of this treatment. That means long-time remission and long-time treatment-free. Then we have the intermediate risk group, and there we have all the options for non-transplant, all the new drugs. And actually then, and that's actually the most important group nowadays, it's a high-risk patient, because there we don't have any clue how to treat these patients, because 30 to 50% of those patients will die in the next 3 or 4 months after having a diagnosis. So, but of course, I will try to convince you that for this low-risk patient, treatment is still the best choice. So, there was one case-matched analysis of the Mayo Clinic where they tried to match patient due to their heart disease, and the outcome for the transplant was better than for the non-transplant. And here, just as a control, you see all patients without matching, so they did even worse. You have already seen this, so it's a paramount that the remission after treatment is the most important thing for these patients. Having a CR or a VGPR means really long-term overall survival. And that's even more true for the amyloid patients than for the myeloma patient. So CR in an amyloid patient is much more important than for a myeloma patient. triggering that you really have to give the best effective therapy for those patients. And also, I just talked slightly about that it's also important for those patients not having a second-line treatment or for a very long time. And also, if you have a CR, the chance that you are disease and treatment-free for a longer time is more probable. So really, CR matters, and therefore effectiveness of therapy matters. Most of the studies talking about overall survival and progression-free survival, but renal survival is also very important. Here you see the curves. If patients have proteinuria above 5 gram or eGFR above 50, and if they have those two risk factors, the likelihood going into dialysis is very high. But again, you can circumvent this in patients if they reach, after 3 or 6 months, a VGPR. So also for those patients, it's important to reach a remission rather soon. Those remission criteria Arnaud was talking about, they are only reliable for patients with a rather bigger clone. That means that the DFLC is above 50. But there are also patients, like 10% of all patients seen in Heidelberg, they have a DFLC of 50 milligram. That means they have a really very small clone. And if you look at the high-dose treatment results in these patients, they are also very, very good. And also for those patients, we could show that remission also counts in these. So they need a DFLC below 10. In opposite to those 40 for the rest, that they really have a benefit of the treatment. So also we can measure these ones. So now talking about those who really can we select patients for treatment looking for biological features. And in the last 10 to 15 years, we spent a lot of time and efforts to characterize those patients due to their genetics. And transplantation 1114 is the most, in 50% of those patients, even more we find this. And those are mostly patients with light chain only paraprotein. In opposite to that, to myeloma, we only find in less than 10% of patients high-risk aberrations. Gain of 1q21 is a little bit more there in 20%, and that's actually, it's interesting that it's an association with lambda light chain restriction, because lambda is much more probable in amyloid than in myeloma. And hyperdiploidy is, in opposite to myeloma, is very rare. So what does this mean for treatment? So if you treat patients with MDEX, which was the gold standard for the last years, and those patients have a gain of 1q21, they have fewer remissions, have a worse event-free survival, and also an overall survival. This is true for MDEX. If you look for patients treated upfront with Velcade, 1114 actually tells you that they will have fewer remission, worse event-free survival, and also overall survival. And then if we checked these features also for the transplant patients, we saw that it was just the other way around. So if you have patients with 1114, they're going to be transplanted, their survival will be better. Overall survival and event-free survival, and the remission rates as well. This was also true in a multivariate analysis for event-free survival. So at the end, it's very important to select the proper patient for your intensive treatment, talking about high dose. And here you see just many different centers or groups with their different kind of exclusion criteria. But at the end, it's less heart disease, younger patients in a good performance status. And then you really are able to reduce TRM percentages much above, below 5%. And this has been proven already in unicenter, but also in very big multi-center retrospective analysis. So first, the numbers from the United States. You see here that beginning in 1995 and ending in 2012, now you have multi-center, day 100 mortality around 4%. Overall survival after 5 years, 80%. So this is multi-center, more than 1,000 patients. they also made an effort to define what is an experienced center. And they said if you do more than 4 transplants per year, you are kind of an expert center, and the mortality again is lower. We could also show this for Europe. We started with this in 1997 until 2010, when you see here that the 12 months mortality really is impressive, much better. And we also could show that center experience matters, but here we defined center experience by transplant for myeloma, and it had to be less or more than 30 or more than 120 transplants per year to get an increase in survival again after 12 months. So we could show in the United States and we could show in Europe in more than 2,500 patients that the results multi-center really has dramatically improved due to better selection. But this was not also true, only true for multi-center. The Mayo Clinic, I think you also showed that paper, just showed that their mortality right now, so 2010 to 2016, is 2.4% after 100 days. So I think that's really impressive, and maybe not worse than some of the more intensive non-transplant strategies. Coming to the question, when should we do the transplant? And most of the studies done are actually first-line treatments. Here, this is unpublished data we put together with the London group. Here we made the effort to treat patients who are really ineligible for transplant at diagnosis, but due to their very good remission they reached after Velcade treatment, they went into a situation where they were eligible, and either we transplanted them as consolidation, so without a relapse, and then you see the overall and progression-free survival here, or we waited until they got first signs of a hematological progression and transplanted them then, and you see that the curves here don't look that good. So I think it's still a debate when should we do the transplant. This has actually not been solved yet. I will skip this due to time. And actually, I could skip this because I was not aware that you also talk about IgM. IgM amyloidosis is very rare, and we have actually no good treatment for this kind of disease because the remission are very poor. Even if you treat those with B-cell lymphoma type of chemotherapies, you see here only few numbers here, but the remissions are not very good, and the survival is also not that good. And we even tried now, we even have published first experience with new drugs for B-cell lymphomas, like ibrutinib, and even those drugs didn't work in these 8 patients in IgM amyloidosis. And we know for just a few patients that high-dose treatment with high-dose melphalan or BEAM really leads to very impressive remission rates. That's another topic which is not really well studied in the last years, but there's now one paper from the Boston group looking for treatment and quality of life improvement. And this group could show that improvement over time after high-dose treatment is more significant than for the conventional treatment. So here are my conclusions. High-dose treatment with autologous stem cell transplantation is the first-line treatment of choice for low-risk patients, transplant eligible in experienced centers. The goal of therapy we have to think about, if it's really to induce a long-term remission and a long treatment-free time, I think high dose is the choice. Effectiveness against the clone matters most still, and it is also important, as we just heard, that the drug, the NEOD-001, who targets the deposit amyloid, this trial just failed. So for AL amyloidosis, still the proper treatment is the treatment against the clone. Uni and multi-center results have further improved dramatically, so better overall survival and lower short-term mortality. I have shown you the data, and the long-term survival is excellent. In most of the series, it's better than 10 years in median. However, I think that's very important, and Arnaud just mentioned it. You have to use features of the clone for decision making. So how big is your clone? How big is your in gradient or your DFLC? How much clonal plasma cells you have in the bone marrow? Which kind of genetic aberrations you have, and also if it's IgM or not. And if you have considered all this, you should discuss with the patient if they are going to be transplanted or not. So this is the first thank on the center in Heidelberg. They helped me to really create the centers in the last 10 years there. We need a lot of colleagues from different kind of professions, like rheumatologists, nephrologists, and cardiologists, and also happy to get funding from the left side here. And I thank you for your attention. And we will celebrate our 10 years of having the Amyloidosis Center in Heidelberg at the beginning of October. And I have already invited Arnaud for this, but not having a debate again, I would say. So thank you for your attention.